talk about Disick in challenging situations and why he chose Disick to do Disick in these cases.
Thank you, Dr. Devati, for including me in this course. And good morning, everybody. So my talk is on why did I choose Disick here, some of the case scenario, and we'll discuss after this my talk. So you know that this is the DMEC, the era of DMEC, and I do a lot of DMEC, and the main important factor is good visibility, and there are other factors also. So if you see this for last 3.5 years, I have done more than 800 DMEC. My ratio is now last year 275 DMEC, and Disick may be around 40. So what are those cases where I cannot do DMEC? So the first indication is extremely poor visibility, some cases of post-RAB or post-tube, some post-PK failed graft, similarly some post-failed Disick graft, some CHD patient, aphakia with very large pupil or very large optical iridectomy, some of the post-AS cases when the Disick tissue is damaged, and some failed DMEC eyes. And there are other indications, those are not related to actually the visibility or other factor, extreme of ages, less than 3 and more than 90 years of age. Head positioning where there is a huge problem, patient is very fragile or weak, you cannot take that patient for a second time for rebubble. So first one is Disick in presence of poor visibility. This is my very old video, maybe 2008, and you see that this patient is bilateral FECD. The other eye has already had infection and has a scar, and so what is the choice? So that time PK and ECCE was the choice that time, but I did manage to do, I call it the double manual combined technique, and this video got the best video award in ESCRS, and I did SICS, a little bit blind SICS, then I removed the cortex, whatever I could see, and then some of the epinucleus, and then put PMMA lens, and next I put a Disick lenticle here, and I used actually, that time knowledge was less, I used actually the reverse 26 gauge needle to cut the DM for desmatorexis and remove it, and this lenticle insertion is like a teco insertion, and I put it there. And you know that this patient was like this after, say, 4 to 6 weeks, and 12 weeks post-op, and patient enjoying 6-12 vision. This patient recently died, and he maintained very good vision. He didn't go for the other eye operation, was doing fine. So these are some of the cases where, but this type of cases now I can do DMEC with IOL. And this patient, you see that tecofold is not a bad technique. If you stick to a same technique, I did at least 1400 teco technique, and this patient over 12 years, you see the cell count, 1528. So it can be replicated over and over again. This is another patient, you see that referred for PKIOL from a long distance, and he has a positive history of HSV endotheliitis for repeated attack, 4 records available with it. I thought other eye Disick, I thought I'll be doing PKIOL. He's a teacher from a long distance, probably one go. And then there was no active inflammation. And I took the patient on proper protocol, oral prednisolone, oral acyclovir, and explained prognosis that something might happen. And then I started this patient on like PKIL, but on table I thought if I could do like phaco in this case, can I go for Disick? So that was the only part of visibility. And I did phaco, but the tunnel making, external tunnel was like 5.5, but internal incision was only 2.8. I did phaco, very difficult, but could manage it. I believe most of the corneal Disick and defect surgeon, they are very good phaco surgeon. And then the difficulty in these cases are that descemet stripping is difficult. Then post-HSV endotheliitis, I have a series of patients, both Disick and DMEC. DMEC last month, it was published in Cornea Journal, 19 or 21 cases. And you see that while scoring, where it is more affected, DM is strictly adherent to that. You cannot remove it properly like other cases. So this microscope is very helpful. This is the Lumera microscope, though no financial. Again, that TECO, this is TECO after say, this might be 2015 video. And this patient I did same. Then this part is like your regular Disick. And you see that patient on all this medication, oral steroids and oral antivirals, and this is the day 7 picture, horrible picture. And you see that probably it has stromal element has now come. So I keep on the same treatment, and you see that after 21 days, this is clearing. And you see that this is after 6 weeks, it is more clear. You see that after 3 months, it is much more clear, little bit of lipid keratopathy kind of pictures. And this is after 6 months, and the endothelial cell count is so good. And patient still continuing oral for 1.5 years. Similarly, this type of case, what will you do? This is the same kind of patient, multiple attacks of HSB in various form, and you see that the visibility is just like that. And again, one-eyed from Tripura to Kolkata. And I did DMEC in this case, just 1.5 years back, and you see that day 6, day 15, and this is 9 months. The patient is a farmer, back to the field. But if you do PK, you cannot do. Then next is the difficult one. Again, partly the visibility is the problem, partly the air management is the problem. So this is my teacher, ENT teacher. You have all read his book, some of the Barin Rai Chaudhuri. So this is the picture. You see the huge bleb, but visibility is so poor, so poor. So I thought that I could do that bleb repair and scleral patch graft in the same time. That this is, you see that after 4 weeks post-op, graft clarity is 3+. This is after 2 weeks, after 2 years, you see that the vision is 20/40 and he is doing perfect. So there are some tips and challenges in this. If you see that, so you do all these things. The section should be corneal. Normally we go sclerocorneal tunnel. DM stripping is like as before, but while you inject air, try to look the perilimbal conjunctiva. You see that the air bubble is going where? So you see that you cannot achieve optimum tamponade. So more bubble is coming in the peribulbar. The more you give air, it gives, the bubble comes in the subconscious space. And this patient, so what you do? You just keep the patient lying there for 45 minutes, 1 hour, because your tamponade is not that much. So it is not 60, this is late 20s or early 30s IOP. So you keep the patient like that. So these are the points to be remembered, the bleb condition. So first give trypan blue. You see the trypan blue is leakage in the bleb area or not. If it is not, you are fine. If it is coming, then you have to take all your things. How do you manage this? Air injection slow, very slowly, optimum tamponade. Then the same, even if you touch this area, that the problem will be there. So this area, air bubble is where you just hold with a forceps and air is leaking. So Disick in post PK, fail therapeutic, all has been discussed, but if you do the ASOCT, those are the posterior bump you see, and your graft size will be determined by those bumps. So you do all 4 quadrants ASOCT like 3, 9, 6, 12 position, and donor thickness thinner the better, and you take a smaller graft. So centering is sometimes difficult in post PKIs. Then this is the easiest way to center it. You give stab because the posterior mismatch is there, many of the cases. So fluid drains. Also you can center it very nicely from the top of this. So your venting incision as well as centering you can do with this. So you do perfect centering. The same port you can use again and again. If you see that fluid is coming out through this thing. This picture you have shown, but I am showing how difficult, the same case what Shoham was showing in the left hand video. You see that what bleeding can happen in the left hand side. Mature cataract, and you see that while doing this synecholysis, the bleeding started. So normally the post-therapeutic, these are the problem. And you see that DM rexis, you always do it smaller. In post cases, you see that blood started coming. So in these cases, obviously the DMEC, blood is the killer for DMEC surgery. You cannot do DMEC. So I managed to do phaco, very soft cataract, so used to so in the bag I will, all this thing is there. But bleeding is going on. Bleeding is going on. We put you see the bleeding is coming during insertion of IOL. Then you put the graft, still bleeding is happening. So you put the graft in spite of bleeding is happening, because you cannot stop these multiple oozing points from the periphery. So you manage it, center it, and then give venting incision. So you secure all the ports. You give venting incision. You see what is coming. So interface, so much blood is there. You give venting, blood is coming. But this patient is this patient. So ultimately this patient do good. So another problem is RCM while doing therapeutic PK. Some of the optical PK also, you see there are 2 videos. One is very thick RCM in the right side, and left side this RCM is thinner. But you have to, sometimes you see the 2 layers are coming. One is thinner RCM, then you actually do the DM rexis. Probably you may not do the DM rexis in this case. So you just see this thick RCM versus thin RCM, then you do desmorexis, or you can go with the Disick kind of thing. So these are the picture of this photograph. This particular lady, I remember, almost 8 years, one-eyed. Very poor. But we did free for this, and she is doing so good. Disick in shade, the Vanati has shown the beautiful photograph. Like this is The difficulty is the DM stripping may not be perfect. What she was showing that it is fine, but you are not sure that you have removed, then DMAC, forget DMAC. Because those are the, again, the DM attachment and these are the child. So positioning of the child is another issue. So this is a, with shade, with Salzman nodular degeneration, I staged it because to see how the things are going. Then the corneal thickness was pretty high. I did dissect, but the clarity usually comes much, much later, maybe 6 months, or gradually it gets clean and clean and clean. Disick in aphakia is a problem, especially if it is a large pupil. And I'll show this. This is the patient, you see that. That patient, again one-eyed. You see the age of the patient. So we can do Disick, and we are recently doing air-assisted donor insertion. So these are the ideal cases. This surgery was done by Shoham. So I am showing this. You see that both anteriorly there is a lot, and in the DM there are some kind of epithelial RCM. What kind we do not know. Probably epithelial ingrowth. Long time aphakia done, 35 years. You see the pupil is halfway, it is not there. So we didn't use a single drop of Hilon in this particular case, except that to smear the wound. So this is air. This is a very nice technique for ACIOL, post-PK, and we are recently using this. So you just put it there, and in presence of air, you put the thing in. Yours should be cornea dome parallel. It goes so nicely, and you are manipulating from the stromal side. So air is remaining there. So we did not to unfold it, and we are doing many cases nowadays, this type of difficult cases, and this patient, perfect tamponade, then you do little venting. This is the end of surgery. We keep the patient for more time in these particular cases because we know that air is more important. And you see that post-operative, this is just 6-day post-op. 6-day post-op, you see the graft well attached, patient is 4/60. Happy, very happy patient, one-eyed, 85 years old, very happy. This is I had done about a year back. If you see the ASOCT picture, you see what is the pupil. Same method, the upper part, lot of corneal scarring is there, not edema. And patient lower part, that acts as a very good pupil, and patient is like 660 with +11, one-eyed, and they are doing fine. So Disick in TAS, this is very important. I have actually 3 cases, intraoperative conversion of DMAC to Disick because of TAS, for 2 reasons. One is bleeding. Second reason is you cannot strip the DM. In some of the, lot of DM folds, lot of scarring. So sometimes you need to take, again, reverse 26 gauge needle to cut, actually, that is not score, actually you have to cut it. Then you remove, you see some remnants, forget about it. And sometimes stuck with the fibrin membrane, it's like a fibrin glue, it doesn't open. So you forget about that DMAC graft and put a Disick graft. So this patient I did 12 years back, I think, no, maybe more. 12 years back, again this patient, 2006 and 14 years back, this patient maintains with 1400 tecofold. It is not bad. My not all secondary failure is only few. Thank you very much. The extreme challenging cases, endothelia, better try for a Disick. We welcome you to our new hospital, will be coming next to Venu. Now we can take up question.
Yes, thank you, sir.
So 14 minutes are there.
We have a lot of time, so any questions you can. Sir, are you still using venting incision?
In some of the cases. And some of the cases, venting incision is post-PK, yes. Post-PK, yes. Because sometimes it doesn't match the curvature. So post PKES, sometimes these aphakia cases, where you are not sure about your tamponade, post VR surgery, aphakia, these are the cases, post trap, tube, these are the cases where we know that you see that whenever you give that air injection, last burst, the cornea gets little cloudy. When you do not see that cloudiness, your tamponade is not adequate. So you give venting incision, you see some fluid is coming out. So you give more air. And you wait for little more time. These are the no 10-minute business in this thing. So you wait for, because these, I always say, which one is more important? Rebubbling is important, or air going is behind is the important. So rebubbling is more important because these are the fragile patient, 85, only one chance you will get. So you give 30 minutes time, 45 minutes time. They can actually lie in the same. We take up those cases, maybe the last case of the day. So this positioning will be much easier. Hey, yes.
So there are two questions. What are your post-op regimen for antiviral? How long you continue and what is the
So antiviral, recently we published that, and all are PCR positive cases. So what I do nowadays is we see the PCR, it is PCR positive, then before operation, 7 days before operation or 10 days before operation, I do another PCR. So negative, then I do the surgery and I start antiviral 7 days prior to full course, either valcyclovir or acyclovir. Okay. And prednisolone, if the patient doesn't have any contraindication, to give prednisolone. 7 days before I start, and then operate on 7th day, same dose regimen for another 7 days. Okay. Steroid tapered off by 1 month time. But the antiviral continued, one patient is continued because one-eyed, 2 years antiviral. So I have shifted to acyclovir to valacyclovir. Valacyclovir is the same, it is a product for acyclovir. So the compliance is much better, once daily dose. Okay. Cost doesn't matter because it is only 50 rupees. Acyclovir 2 tablet costing 30 rupees. So it is fine for the patient.
And how do you manage the interface infection? Like one of the patient which was shown, or any of this fungal
interface infection, Disick versus DMEC, a lot of things happen. The Disick, you have already a thicker lenticle downwards. So if it is a small pinhead type, you may take a chance. Mostly fungal, these are usually after 2 weeks, 3 weeks it comes. And mostly candida, these are these. And a lot of reports are there. So you give direct stab incision on the site. Wash it. Give amphovi. Okay. And also the other protocol for systemic antifungal, if it is near the periphery, so that, and topical. This I had one patient, and also Elmar too has published one in Cornea Journal, intra and intrastromal around that area. Okay. So it clears. But if it is a large one, so what will you do? You take the patient to OR, take out the lenticle, give intracameral injection of whatever, mainly amphotericin B. Wait for a few days, how the infection behaves. And you can do a regraft, redissect after some times, maybe gap of 6 weeks to 12 weeks. So this is a normal protocol, and we had actually in our total hospital, maybe we have done around 3,000 dissect, and we had actually, I can remember that 6 or 7 eyes we had interface infection. We can, one eye we had to, that we did everything that recurrence, we had to eviscerate, 3-4 grafts done. But most of the eyes could be salvaged, and we did at least 50% eye we redissect within 3 months. Okay. So these are the things.
So and the last question regarding donor preparation, like how do you judge your initial entry? So you do a pachymetry pre-op, or you just go 2/3, 3, madam? Like, what are your protocol for that? To
No,
make a
the
ultra-thin graft?
Pachy, of course, whatever Pachy we have on the donor cornea, eye bank cornea, it's not very exact.
Right.
So most of the time, like you assess in the slit lamp what you see accordingly. Generally, I always use 300 micron depth. The gauge,
For manual.
this one for manual. With that I'll do. And for the automated one, generally I go for 400, or if it is really thick cornea, only 450. Around 400 micron head if you choose, generally you will. That's why I said we can do even a second pass, or after passing the thing, if you see it looks like thick even in the automated one. I used to keep it on the microkeratome itself and do a manual dissection. Very thin pocket, and usually the interface is smooth only. Like you can do one more layer, you can take it off if you feel it is thick.
So what about
So I have a different answer, a little different. So what tissue are you using? Are you using MK medium? Because we have 50-50. MK medium is 50 to 80 micron thicker than the corneal preserved or Optisol GS. So number one factor is there. So you take my peripheral cut usually 400 or 450.
Yes.
So if it is a MK medium, I give 450. My intention, because in our scenario, we know the corneal thickness in our population is how much? It is almost 80% of the eyes, it is 510,
Yes.
520. It doesn't much more. So my intention is, my grafts are always thinner graft because I go that way. Periphery, you are always 700, 750 like that. So you initiate at the limbus. So you go dome-wise, and your central thickness is 80 to 120 micron in my, I have done, published also. It is the similar, but MK medium versus corneal is definitely important. And second important point, ask your, because sometimes they forget to keep the thing in the what temperature for 1 hour. So thawing is one of the important factor to determine the thickness, because it reduces by another 50 micron.
Okay.
So those are two important factors.
Thank you, sir.
Yes, Mamta.
Sir, can you give us a guideline regarding the sizing of graft, say for clean cases or for cases where we have failed optical PK? Suppose someone has already done a 7.5 mm PK in the initial case. So how one should go about it?
So clean cases, you just measure the overall diameter of all the things. Our cornea is smaller cornea in Bengal. We know that 9.5 to 10.5, that is all. So our direction is keep at least 1 millimeter working zone on the temporal and nasal side. So that way your graft size, with our average graft size is 7.75 or 8 max. But for DMAC this is better. DMAC average graft size is 8. For Disick, because you have a thicker lemon, there is a chance of iris touch, all these things are happen. For PK, again you have to see the diameter, and posterior ridges are very important, host graft junction.
As an anterior segment OCT we have.
Those are very important. So normally therapeutic PK, it is very easy. So you have a plenty of space.
The
But
largest graft is there.
But if it is a 7.5 millimeter graft initially, then you need to take a call that which side, because, and your, that donor lenticle should be thinner. Your mentality will be that I will be go a little thinner Disick in this particular case. So whatever if it crosses, because centering is difficult, crosses, so it is. If it is a thicker, then fluid seeps in through this and you have a detachment. And detachment rate is higher in post-PK cases.
Sir, in initial post-op phase, say for 1 week, if there is a localized edema, and in anterior segment OCT also we can see there is a localized detachment, how to, I mean,
That
do
is
we need
with
to
the
intervene in every case
With the Disick.
with the Disick? Yeah.
So the area, how much area? So normal thumb
if
rule
it
is
is-
that 1/3 versus more than 1/3. If it is less than 1/3, you can watch that patient with all that direction, what is the size of the ear, and try to manipulate that ear on that side. So positioning, head positioning, like right lateral, left lateral, whatever, even chin up, whatever. So that positioning is, if it is in the more than 1/3, then
Then
you
we
have
need
to rebubble it.
And superior versus inferior detachment, does this also make a difference?
Superior detachment to easier. So because air always remains there. So superior, you can watch more actually. Superior, and that day we had in the junior surgeon, I said, okay, watch it. So after 1 week, he again see this patient, and usually it sticks.
Thank you so much, sir. Thank you. Ma'am.
So such cases you use air only or the
I,
gases?
I never use gas. In my 3000, my series is almost 3000 EK series. So I never use gas, only 3 or 4 where re-detachment happening. So re-detachment. So one rebubble fail, then I take this patient for, and that time I ensure to do a PI. Especially DMEC there is no matter, but PI for Disick cases. So I do an external PI because internally the graft is detached, so you cannot do external PI. Then wait, and then we do. Any question? So we have another 3 minutes time. Any question?
Hi, very nice lecture. I'm Tyler V from Hadassah, Jerusalem. And right now we are doing reverse transcriptase PCR for, to check if the herpes is active. This is a much more accurate measurement to see if the cornea is in active infection. So before
Somehow in our part we see lot of viral endotheliitis. So we have, in my EK series is maybe now I crossed 70 patient with HSV endotheliitis, and these are the, and recurrence is there, of course recurrence is there. So in my DMEC series I published 19 patient, in there 3 recurrences happened, and sometimes recurrence in a virulent form. Initially it was HHV endotheliitis. Later on it is like all layer endotheliitis, all layer HSV keratitis. That is the point. So, but PCR is a guideline. You have a safeguard. You have a good feel that while you are doing the surgery, the patient is at least negative for PCR test. But if it is positive, wait. Give the patient antiviral. I have 2 patients with CMB, and you know the CMB is a costliest disease. So CMB, I did DMEC, and both the patients are doing fine, but the cost is more than 4 lakhs to them. Medicine got 18 months going on. Still I do not know when to stop.
Sir, even in CMB they say even topical ganciclovir.
But say that then the question is our ganciclovir topical versus their topical ganciclovir. This always bugged me that our ganciclovir probably does not work. That's why we are still stick to acyclovir ointment. But you cannot give 5 times daily.
And the valsiclovir you use in 1 gram TDS?
Usually patient's body weight. So body weight determines 500 TDS or BD. It is fine. It is going fine.
thank you.
Thank you. Okay, thank you very much.
Thank you very much. Very lovely discussion. So.